Hey, Victor. This is gonna have to happen. We're gonna have to mute that. Hey, if you guys are on Zoom, do you want to tell me that you can hear me? So that. Oh, Victor, thanks. We only have 2 interns in front of me. Excellent. All right. So today we're going to do a fun winging it of how do we take someone who's dying and make them not dying from a respiratory standpoint, because I'm going to drill into you, not just the first 5 things I always talk about, but the subsequent 5 things. So we like to put things in lists of 5, but this is going to be 10. So let's do a quick review so that we can kind of bounce off the platform. Otherwise, we get muddled in kind of the July 1 stuff. So I'm excited to see you here, Jordan. So tell me, you come down to the emergency room to do that resuscitation, and you get a patient who is intubated in the field, hashtag Hamilton County EMS, and ED says, hey, they're on a vent, and this is their settings. Your patient is a 72-year-old female, and she is 5 foot 1 inch tall. I want you to put her in the box of ARDS, but before you do that, I want you to tell me what the definition of ARDS is. Well, it doesn't have to be pulmonary. Scorpion bites can give you ARDS. So you're right? It's bilateral infiltrates less than 7 days. That's not cardiogenic, so no heart. Cool. That will be on your boards like 4 times. They're going to be like, hey, this person's got an EF of normal and they've got bilateral opacities, which is it? And the answer is C, ARDS. All right. So that's most of the definition, but Volberg's going to help you out on the hypoxia part here, and he's going to tell me all about how else we diagnose this. Okay. And just for the spectators on Zoom, what's the P and what's the F? And where do you find the PaO2? On the arterial blood gas. Cool. And how would we classify this? You're calling upstairs, you're like, hey, Dr. Cohen, I got a 72-year-old female. Seems like she died in the field. They put her on a vent. I think she's got ARDS. She's got bilateral opacities. It's been definitely less than 7 days because she was at PT 4 days ago. She seemed fine. I put a probe on her chest. It's not her heart. Can you tell me kind of where, how would you further classify? What do the 3, 2, and 100s mean?
So it's differentiating mild, moderate, severe ARDS.
Okay. Which one's which?
So mild would be 300, 100, and then 200 is moderate. 100
All right. Anybody not know this? No, of course you wouldn't admit to it. So Jordan. Oh, yeah. We got a question in the room, and that's going to be from Eli. PGY3 Eli, who is going to be a cardiologist. Do you need to have a closed circuit to have an accurate PF ratio? What do you mean?
So it's not, they're not.
Okay. Mhm. Yes, PF ratio is solely your arterial oxygen pressure and the fraction of inspired oxygen. So if I were to hold you down right now and let Volberg try an ABG on you, then if it was 422, it would be 422 over 0.21. So yes, it's a great question. You do not actually can so that brings up a concept of ARDS who does not have a bed. Yeah, all the time. If you look at some of our COVID notes, ARDS, acute hypoxic respiratory failure with ARDS, and they're on 100% vapotherm because their PaO2 is 112, and so they're actually meeting criteria for moderate ARDS. So yeah, it's a great question. Key's here. He's listening in with Victor at Dodson. Alrighty, so Jordan, I want you to put this lady on the initial box. I want you to be able to call upstairs to me and say, I'm bringing this patient to MI 20 and I have put them in the box. So tell me what tidal volume you want, respiratory rate, all that stuff. And if you want, we'll just assume the ED did an ABG up front. Do you want that first? That'd be great. So her initial ABG based on ED. And before we go any further, we have is that a PA student in the room? What's your name? Ryan, welcome to the party. Ryan, could you interpret this arterial blood gas for me? Take a gander. I don't bite unless you're a PGY 2 or above. Okay. So anyway, just tell me what the parts are. All right. CO2, then O2. So by convention, pH, PCO2, carbon dioxide, then oxygen. And so could you tell me what this person's PF ratio is? You're going to kind of help Jordan out behind you. So you take the oxygen, as Eli was mentioning, so and Volberg defined, so it's your PaO2 over your fraction of inspired oxygen. So what is this person's fraction of inspired oxygen right now on the vent settings that are right above it? So remember, your oxygen is this one. Yeah, so, and it's actually a percentage, right? It's 100%, so it's 1.0, so it's 150 over 1, which is 150. PF ratio is 150. So what stage of ARDS would this be? Yeah, so it's moderate, so 200 down to 101. All right, great. So you've already diagnosed this patient with moderate ARDS. Cool. Jordan, what do you want to do? Step one. What's the mainstay of ARDS therapy? Lung protective strategy. So how would you define that? Yeah, starting tidal volume of somewhere between 4 to 6. Let's go with 6 cc's per kilogram of ideal body weight. And what is this patient's ideal body weight? I keep calling on other people to let you Google that. Tanner, what do you got? So 6 cc's would be 300? All right, so we'll set, and then what's her 8? What's the range? So I make the argument, and feel free to do this. If you have a patient who meets ARDS criteria, start them at 6. If you have a patient who doesn't, they're just on a vent, they're a stroke, whatever, start them at 8. You'll need less sedation. You're not worried so much about the lungs, and it's still safe enough. But the lower the better in ARDS, provided you can meet your goals. So start at your 6. So let's start her at 300. And tell me the rest of the settings, Dr. Austin. We're gonna make it so y'all can rattle it off. Well, tackle it in order. What's the respiratory rate there? Oh, you want a plateau pressure? Now we're going advanced. All right. So you do a plateau pressure on the initial things here, on the initial setup, and it's 42. Because the tidal volume was 600. Okay, so you're going to drop that, so it'll probably get better. Your respiratory rate's 18. Change or stay? All right, you want to go to 16. All right, and to what? What do you want? 25. So much for even numbers. All right, and so the plateau is 42, and the SpO2 is 95. What do you want to do? Do you like an FiO2 of 100%? Okay. Yeah. Just pretend I'm an RT. You got to tell me what to do. All right, so 80. Okay. Like, are we in the ED now? Or are we in the intensive care unit? Are you going to be intense? Or all right. So you want to go to 80. All right, cool. And it really is this simple. So if someone's FiO2 is 80, seeing a PEEP of 5 should make you cringe. And so Mims is falling asleep back there. So Stick, what do you got? Yeah. You want to go, all right. What would your PEEP be though? If, like, let's say you needed 80, like SATs are 90, 80. Yeah, so 14 is a very reasonable number. So it's just using the chart, easily Googleable. Save it on your phone. All right, so let's make some room here. Is there like a clear all? Maybe. All right, so your settings now are at 300, 25, 80 over 14, and you get a gas in an hour, and here's where you're at. Right. Thoughts? Yeah. Your residents behind you, your interns and your residents went really bold with the changes. What do you think of that? Does that make you happy? Make you sad? What if I told you that they went so intense they literally nailed it on the first try? We didn't have to do 7 different gases. So could you tell me what? No, seriously, that's perfect, right? You guys you cut the tidal volume straight down to 6. You went up on the respiratory rate, and the FiO2 and the PEEP you got back even, and so your PF ratio went from 150. What did it go to? So 95 over. So it dropped a little bit, but it's fine. You're doing the right things, right? It's early on. You don't know what's happening. Maybe they're still getting worse. Still not inflammatory cascade. But what? Yeah. So who just said that out loud, Eli? So permissive hypercapnia. What do you know about that? No. Yeah. So you're right. This gas is a little acidotic. But what happens if you take your tidal volume and you decrease it, or you take your respirate and you decrease it? What happens to the total amount of air per minute that moves through the lungs? Well, if you're breathing slower or you're breathing less per breath, what happens to the total amount of air? Yeah, it goes down. So your minute ventilation, appropriately named because it's the ventilation you have in a minute, goes down. And so what number on your arterial blood gas varies with your minute ventilation? That'll be one of them. Which one do you think? Yeah, so your carbon dioxide, the higher your minute ventilation, the more you blow off your CO2. The lower your minute ventilation, the less you blow off your CO2. So we lowered our minute ventilation by cutting it from 600 to 300, and we didn't quite double the respiratory rate, so it wasn't an even change. And so I'm saying, sweet, we're at 7.25. Shapiro, tell me why 7.25 is my favorite number in this. Yeah, so Shapiro said the goals for permissive hypercapnia is that your pH should be somewhere between 7.2, 7.25 or so, and I completely agree. What's your PCO2 goal though? You don't have one because who cares? Right? What if they've got, obesity, hypoventilation, and their intrinsic bicarb is 40? Well, your PCO2 might be 120 before you're down that low. So cool. Now we'll get to the fun stuff since everybody got through the review. I think I've worked with everybody except Smith here. Who? What? How is that possible? Really? Oh, I know what it was. Because yeah, you've been on and I've been there, but never, huh? Ah, missing out. How could you? Alrighty. So, all right, so let's do like the other 5 questions you're going to get on the board / here's what I want you to know. So all of you let's just review what we did real quick. We took a patient, you identified their ideal body weight, you identified the Berlin definition of ARDS. You appropriately cut the tidal volume, you cut the respiratory, you went up on the respiratory rate appropriately. Had a little indecision initially, but we got on the right train track. Dropped your FiO2, went up on our PEEP. Cool, we're on the table now. The one thing we didn't do is check what? Plateau pressure. So let's say that your plateau pressure on this new one was 31, and you wanted to modify one thing. I'll say that her SpO2 over the last hour is 93. Any other change that you'd make to really just like put it in the ARDS initial box? So what's our P-plat goal, our plateau pressure goal? Less than 30. Who said 15? Twice that. So what affects your plateau pressure? So people do it, and what else? And your tidal volume. And those are things you can control. What about on the patient side? What's affecting their plateau pressure? Because if I set you on these exact same ventilator settings, your plateau pressure would probably not be 31. Compliance, right? How stiff the lung is. The lower the compliance, the less compliant, the stiffer it is, the more pressure you get for every amount of volume. So you can heal them, right? Antibiotics, diuresis, all that stuff. But right now, you got to set at 93, make one more adjustment. Free for all. You could. Okay, yeah, you could definitely go down a bit and then maybe balance it with your respiratory rate. But she's setting 93. What else could we do? This would be a great segue into what I want to talk about, actually. What's that? Yeah, you can come down on it. So what I want to burn into everyone's mind is I think you guys are doing awesome with knowing the recognition and setting them up now, because I've been on service a couple of times and I've been told, hey, Dr. Cohen, I've got a patient with ARDS and I've set up the box, and I go in there and they are on like 6.5 cc's, plateau pressure is 29, their P per FiO2, their SAT's 92. And I'm like, gold star, you might as well go home. Don't go home. We got more to do. So yeah, if you drop the plateau by, or sorry, the PEEP by 2, the plateau might go down by 2. It's not always linear, but it's a good way to think about it. So if you went, let's say, maybe to 70 and 12 or 60 and 12, plateau probably like 29. So what should your goal every shift try to be to get the FiO2 down to? You got to pick a number to get the FiO2 down to this number or better. What would it be? Yeah, that's ideally yes, but let's say they're still pretty sick. So there's a cutoff number I'm looking for of when we do other things. It's actually 60. Yeah, so what are these other things we speak of? Paralysis and proning, right? We'll talk about the literature behind each one for a hot second here. But all of them happen with a PF ratio worse than 150, despite maximum ventilator optimization. And despite that, you have a PF ratio less than 150 on more than 60% FiO2 with appropriate PEEP. And so every shift, I'm constantly trying to get down to 60% with optimal PEEP based on the table, because if it's higher than that, we got to start thinking about doing other things. So, Goldberg, you look very excited with your, is that a ski jacket? All right. Real quick before we dive into kind of the fun stuff that I want you guys to know, because we've handed you the keys to the initial setup. Like all the attendings, we expect you to do it. I'm going to start handing you the keys now to making bigger decisions. I will preface this by saying, please don't prone anyone without telling us. But I'd be cool if you were like, hey, I'm going to prone this guy because X, Y, and Z that we're about to talk about. Like, that would make me warm and fuzzy. Kind of like the inside of Goldberg's jacket. So we just said, I'm going to make some space on the whiteboard real quick. Everybody's cool on what we talked about, right? Any questions or anything? Concerns? I got some furrowed brows in the front. Good? All right. Eli. Peak pressure. Yeah. So the question is, like, what is peak pressure, or why peak pressure? What do I do about it? So peak or plateau, because those are two different concepts. All right, let's define that. Let's take 2 minutes here to go through peak pressures and why, for the most part, I don't care. So you've got a pressure waveform. Pressure on the left, time on the bottom. And your breath looks like this. This is your plateau, and that's your peak. It's kind of like a rounded tabletop mountain here. But let's say it looked like this. And what's happening here is we're hitting plateau pause. We're hitting the button to say, sorry, inspiratory pause. So we're saying breathe in, I'm holding the button. It's gonna, once it hits the max, it's gonna just hold the breath for a second. And so you get this little plateau there. So we still all agree. Oh, good, my text didn't show up on there. Dinner with the, yeah, it's fine. All right, so we all still agree this is the plat, and we now can clearly see this is the peak. So what does each one represent, Eli? The plateau we just covered. And just like on a mountain, the peak is the highest part of the rock. What does it mean, though, clinically? Okay, so let's say that these are two different patients. Is there a clinical difference between them? In one of them, the delta between the peak and the plateau is pretty big. The other one is pretty minimal. We'll call this 5 and we'll call this 120. The plateau pressure is okay. So saying in this patient, the lungs are probably okay, but you're getting a peak alarm. And so this is where we're giving you the tools to say ventilator as a diagnostic modality, not just a treatment. Dare I say treatment support device. So clinically, what does that mean? You see a huge peak, normal plat.
It means there's something wrong with the flow.
That was Victor. Victor, tell me more.
So that means there's not something wrong with the lungs per se, but with the flow, something either the tube or the lungs, like there could be some mucus in the lungs or the tube kinks or something wrong there rather than the lungs itself.
So something is narrowing the circuit, whether it's a kink tube or a mucus plug or bronchospasm. And I heard the R word in the room, it's the airway resistance. So airway resistance being high means one of those things is probably true. On the other hand, this guy right here, you're saying the lungs are probably bad, right? Let's say this plateau here is 18, and we'll say this one here is 32, the peak is 30, 37. And this is 50, what's the problem with the patient? My breath's the same. I just don't draw well. So we said a high peak pressure is airway resistance of some sort. We defined kind of some options there. We said that an elevated compliance, a worsening compliance causes an elevated plateau pressure. But in this one, you've got which one or both? You got both. So this is a patient that's got bad lungs and airway resistance, whether that be bronchospasm or mucus plug or kink tube or something like that. I had a peak alarm yesterday we had to figure out. It turned out that the suction, the Ballard, the suction catheter was just enough to cause an airflow problem. So a lot of times when I'm called and they're like, the peak alarm is high, the peak alarm is high. And first thing I'm going to do is an inspiratory hold. I'm going to see what the delta is there. And if it's 5, but if it's like 10, 15, 20, start treating it. Listen for wheezing, get a chest x-ray, check if they're intubated, make sure they're intubated because you're doing it. Check the tube, and how do we treat that stuff? Well, if they're wheezing, steroids, bronchodilators, etc. If it's a mucus plug, you can try suctioning it, or we can put a bronch down it. Those kind of things. Cool. Sweet. I wish there was a clear all. All right. So we were saying something about 60%, that I'm always trying to get to 60% because that's the next kind of stuff. So what is the next kind of stuff? So you put them in the box, you get them all nice and nibbly-bibbly on the ventilator, 60 cc's per kilogram, their plateau pressure less than 30. You park their pH through some combination of going up on the respiratory rate and down on their tidal volume to park their pH around 7.25. You're feeling real good, but no matter what you do, their SAT is 89, 88, 87. Their PF ratio is, no matter what you do, below 150, and they are stuck on 80%. What do you want to do? Prone them or paralyze them both? In which order? What does the literature say? Maybe. Wasn't borne out in the Acuresis trial, though. So maybe, maybe not. So you've got a patient who is satting 88%. You've got them on 6 cc's per kilogram. That's giving you a plat 29. And start thinking of these things as linked together. You've got them on a respiratory rate of 30. You've got a pH of 7. 0.25, you're doing great. But no matter what you do, you're on 80% and you're on 14 a peep, and you just can't get them better. So do you want to prone them or do you want to paralyze them? Do you want to do it in a specific order, or do you want to just do one or the other? Prone first. Okay. What are the two proning trials? What was the first proning trial? Fair enough. I get paid to tell you.
Procedure and
Whoa,
Rose.
there-
Or Procedure is
Whoa.
the prone trial, sorry.
Whoa. Settle down there with all the right answers. All right, so Prosiva. So Victor, tell me what Prosiva told us.
Prosiva said that if you prone a patient, that like you get better outcomes if you with early proning.
What's the pathophysiology of proning?
You're asking me?
Well, now that you offered.
Okay. You with the proning, you can recruit more lungs based off the anatomy.
Here, key. Yeah, so you guys are right. So if you put somebody on their tummy, there's some gradients and stuff we can talk about. If you want to talk about like transthoracic gradients and things, and those of you who are going into critical care specialties, you're going to learn all about them. But the biggest bang for the buck is that, remember, the lungs are not like even anterior posterior. You got a lot more in the back. There's a lot more junk in that trunk, and prone them, a lot more surface area for gas exchange. How long do we prone people for? Anybody? At least 16. So if you look at the trial, it looked like this. So at least 16 or greater. So you can do 17, 18, 20, and 4, doesn't matter. What is the only reason we really turn them over is A, prevent some pressure injuries, and B, do some nursing care, mouth care, all that kind of stuff. So cool. So you want to prone them. Fair enough. Prosiva said, hey, it works. Does anybody know how many people in Prosiva, because it came after the first paralytic trial, so paralytics came out first, then Prosiva. How many people in Prosiva were paralyzed? Ballpark. Don't have to be right. Most? Not most. Most, 86%. So really what came out of that was, well, in the original paralytic trial, they had an improvement in mortality. And then Prosiva came out and they had an improvement in mortality. And so then they went, well, we should just do both. And so for 15 years, oh, well, less than that, maybe 10 years, it was paralyze them, prone them. Kind of at the same time. Nurses loved it. And then the Rose trial came along. Victor?
Yes, sir.
The Rose trial from the Pedal Network.
Mm-hmm. In 2019.
Yeah.
They said that the neuromuscular blockade in ARDS there's no benefit to it.
So how did that change management?
That says that you just use sedation with a lower rest, or rather than proning, rather than neuromuscular blockade.
So you don't need to paralyze them. Not with propofol or whatever you want, and completely knock them down. And that more bang for the buck was found with proning. And that proning plus paralytics was no better than proning without paralytics. When do we prone? All right, so you want a PF less than 150. Provided that we did the things we said, optimize vent. So that means you're on the table, your plateau pressures are all as good as you can make them. And you're on more than 60% with appropriate PEEP. Prone them. How long do we prone for? So not just the hours, we talked about that. How long do you go for? When do you stop proning? I see a 3. You want to commit to that? Okay, it depends on the patient. Tell me more. At least 3 times. Good. So what are the exit criteria for proning? At least based on Prosiva, and Rose used very similar ones to my knowledge. Yeah, so Victor, Eli wants to call on you, but don't worry, I got your back, bro. Warren,
Appreciate it.
when do we stop proning people? So it's better than what? You got to pick a number. More apparent number than that one. 150, yes. If their PF ratio is better than 150 on 2 successive gases, I do it when they're supine. Like, let's turn them over and prove that they don't fall back into criteria. So if you have 2 successive gases that they're supine, this is not exactly the trial, but this is kind of accepted. Generally, people do it this way. Then, and it's over 150, assuming that you're no longer meeting the original criteria of you're on more than 60% optimized bed, etc. What else? So they got better. The other one is a 20% improvement from baseline PaO2. A lot of people don't do that because then that leaves you at risk of a lot of you're still not better. And what's the other one in Prosiva they exited on? So they got better, it got better, or well, yeah. So yeah, but more general. Or less general. Something happened during the proning or while they were prone that makes it hard or impossible to prone again. So, for example, if every time you prone them, they have a VTAC cardiac arrest, one could argue not to prone them. We had somebody whose eyeball fell out one time. We didn't prone them again. Yeah, really, it was weird. No, it was a real eyeball. The hospital we took them from was using a rotoprone bed, and they had left them prone so long that their ocular pressure was so big that it had expanded. It looked like you had hyperthyroid. And when we moved them, it popped out. It was a horror show. It was like this much better than being an L&D. All right, so proning, so do we still paralyze? Yeah, if there's, and so there's emerging data on whether or not, none of this is gonna be on your boards. This is what I want you guys to know to take care of the patients that we all see together. So there's emerging data that you don't need to necessarily fully paralyze them. You could maybe even use a lower dose just so that they're passive on the ventilator, but I don't think it's gonna show any improvement. And so it's more of a, if they're super desynchronous, no matter how much sedation and you're going to dangerous levels of sedation, like now they're on pressors from it and all that, you could try to get away with a little bit low dose impacts. What other adjunctive therapies do we use? So you put them in the box, you've got them on good ventilation, still didn't work, you proned them, you paralyze them, they're on their belly, their PF ratio is 92. All right, so brand name here is Velletri. Ooh, Eli. So your DEXA ARDS. Yeah, so the CRP thing is from like COVID literature, but DEXA ARDS predated COVID. And so that was a question of whether or not do steroids help at all in acute lung injury, and was the first one that was positive. So you could do steroids. What else? Somebody said Velletri. So what's the data on Velletri? It's not there. It doesn't. I mean, it'll make your numbers better, but it's never been associated with improved mortality, decreased length of stay. It makes your number better. There are indications for it, certain pulmonary hypertensions and stuff like that, but it's not my treatment of choice. So let's say you get real bad and you get into a situation where no matter what, this is your gas.
ECMO.
Let me finish writing it, man. So this is done. So we've gone back to 8 cc's because we couldn't do it. We're on a rate of 35, any higher, and they auto peep. It's on 100%. It's on 18 a PEEP. Any higher, and their nonlinear overdistension happens. Yeah, that's the only thing. So ECMO Caesar trial, which was the H1N1 2009. Okay, there was a mortality benefit, although it was hard to prove later on. Just the first COVID wave from my former home institution had a 50% survival on ECMO. Now, you could argue that's 50% of people who 100% would have died without it. In the Delta wave, it was only a 38% survival rate. So I guess the question is, the saving an additional, this 40% of the cohort surviving of people who are for sure going to die worth it? And I don't know the answer. Generally. And so that's why it's always self-selecting. And like, who's the right person to put on? And so that's the challenge. If you're a lower volume center, one of the challenges, being very specific of who you put on. You go to a place like Mass General or Cleveland Clinic or Mayo, and they're doing 400 cases a year. It's a little different. So briefly, let's say they get better. We talked about when to stop proning. Let's say you paralyze them. When do you want to stop paralyzing them? When you stop proning. My personal habit is to stepwise reduce whatever you've done. If you paralyzed and prone them, stop proning them, then stop paralyzing them, then start reducing their sedation. ARDS, there's only 5 things you can do anyways. Questions? Comments, concerns? Things that have been on your mind. Critical care things you want to talk about anyways. Weird stuff you've seen in an ICU recently. Weird stuff you've seen not in an ICU that should have been in an ICU. No? Okay, fine, I'm going to. That's really it. I just wanted to come in here, give you guys a nice, good, robust, single, here's what we want you to know. Here's the initial setup. Make it happen. Be empowered now to say, I think I've done everything I can, and I think we need to do something else. Proning is probably going to be your biggest bang for the buck. And let me tell you, it's better to pull that trigger early than to get into a situation where now it may be harmful. Cool? So you're giving me the patient who's been on the ventilator for 2 weeks, suddenly worsens. Yeah, I mean, you're going to get them through that. Now, is there data on people going months and months on it? No, I think the longest person to proceed was 28 days, but that was a very small amount. And I don't think that person probably lived. That said, what else are you going to do? I don't treat it any differently. I think DEXA-ARDS has enough data that that's our current management in all comers ARDS. I don't know where that came from. That, they got worse. Let's go from 6 to 10 to 20. I would do it up front. I think there's data for it. Now the question will be, maybe 20 and 10 was too much. Should we do another trial of 12 versus 6, which they just recently did for COVID, and 12 had a bit of an advantage. So they may reduce it down. They may reduce the base up. Maybe we do 12 for 10 days, and that's the same as 20 and 10. It's one of those things where it's kind of like up and down, and who knows. But I treat them the same, to the point that I no longer really wait to intubate COVID patients. Would you keep any other person on a BiPAP on 100% breathing 40 times a minute for 3 days? And there is data for earlier intubations in patients who are on maximum hypoxia. But then the argument of, well, if their worker breathing is normal and you can provide them that oxygen, it's an argument not to. To me, if you're needing a non-rebreather, no matter what, that's telling me that your inhalation flow rate, you're pulling in hard enough that you can overdrive what the vapotherm can get to, and you're in training room air. And you're using the non-rebreather to create a reservoir outside of your nasal cannula that you can pull from, because you're breathing in so deeply, so quickly, that you're overdriving that power. And so that to me is predictive. And I try not to do that. Now, if a patient's they're turning and they were on the phone and had it for, desaturated for a little bit, and they're using that to get back up, all right, you can make the argument their workup breathing is still fine. But if they're stuck on that, they take it off and they plummet, to me, that's an indication for intubation. And I think we're starting to see that in ever increasing single and now multi-site studies, retrospectives. I'm sure we'll get a larger data-based answer in the next couple of months. But my suspicion is that the management of COVID-19 viral pneumonia will begin to regress back to the mean of the same as any other, if that makes sense. Cool. Thanks for having me. Minimal data,